Hi, everyone, and thank you for the introduction, Rachel. Some of you I know are familiar with this because I recognize some names on the call here. And so, for those of you who aren't familiar with our work, I'm happy to introduce you to what we're doing in the state of South Carolina. And for those of you who are very familiar, welcome and feel free to chime in if you have anything you'd like to add. So today I'm going to be talking about what New Morning does and including some of the reasons why we do the work that we do, which includes barriers to care and what can keep people from accessing contraceptive methods that they want, as well as an overview of a history of contraception in America and some ethical considerations that come along with that. And then I'll talk some about the contraceptive equity and justice approach and give you a snapshot of New Morning's program and also the impact of our program so that you can point people to resources if they need it. So, just a note before I begin, this presentation does include some information that you may find sensitive in nature, including examples of structural violence and racism. And so, if you want to take a pause or leave during these sections, please do. And if you would like for me to share slides that omit that content, then I can also do that. So I'll get started talking about contraceptive access generally. So I'm sure that some of you are aware of barriers to care. Generally speaking, I'll talk of some detail about how this really relates to birth control specifically. So lack of knowledge about methods among patients and providers can be a limitation. When you think about contraception, 9 times out of 10, you think about the pill. There are other methods that are available, and there's also developing technology with new methods too. But if a patient or a provider don't know about those or aren't familiar with them or the medical eligibility around those, then it can be a limitation for patients. An emphasis on abstinence-only education can limit knowledge about birth control and also birth control use. Misinformation and disinformation about contraception runs rampant. I'm sure that you all have heard about this, and TikTok is the kind of big source of late that is talked about for spreading misinformation and disinformation, and not just about contraception, but there is an uptick in misinformation and disinformation about contraception. Restrictions in insurance coverage and high cost sharing burdens continue to be an issue, and I'll talk some about the history of this in later slides. Lack of privacy and confidentiality can keep people from accessing the contraceptive care that they need if they feel like they might be in a situation where seeking that care would make them vulnerable or face retaliation. Inadequate language services for people who do not speak English or accommodations for people with disabilities make it harder for those people to access contraceptive care that they need. In some states, providers are permitted to refuse either providing contraceptive care, or even pharmacists can refuse to fill a prescription for contraception. Some providers still require unnecessary tests or multiple appointments before initiating contraception, which is not in line with best practices. Generally speaking, healthcare inequities continue to persist and keep people from accessing care. Not having primary care and contraceptive care integrated often leads to people having to go to multiple locations to get the care that they need, which can be a barrier. And then, of course, there is social stigma around using contraception in some spaces. So, Rachel had asked if I could go over a history of contraception. And so I know a lot of you are providers and you're familiar with these things. So, I did not include the very, very, very extensive history of contraception, but I picked out some of the highlights that I thought would be interesting for our discussion today. So, people have been using contraception since the beginning of time. And they started using things like barrier methods, including like animal skin or fabric, or even homemade spermicides out of dung and herbs. In the 1800s, there began this development of new technology called cervical caps, the rubber condom, douching syringes, and womb veils. These were widely available in stores and through catalogs with little restriction. However, in 1873, the Comstock Act defined contraceptives as obscene material, which prohibited the distribution of these materials through the postal service or interstate commerce. However, in other parts of the world outside of the United States, there weren't as many restrictions, and contraceptive technologies were still being developed, which would include things like the diaphragm and a contraceptive suppository. In 1916, in violation of the Comstock Act, Margaret Sanger opened what was considered the first birth control clinic in Brooklyn, New York. However, after 10 days in operation, her clinic was raided and she and her colleagues were arrested. In 1918, 2 years later, the Crane decision permitted the use of contraception for what was called therapeutic purposes. Around the same time in 1920, the 19th Amendment is ratified, granting women the right to vote. And in 1927, in the same time period, the Supreme Court ruled in Buck v. Bell that coercive sterilization did not violate the U.S. Constitution. From 1928 to 29, scientists were able to identify progesterone and estrogen. And then in 1936, the U.S. versus One package rules that physicians can receive contraception and information via the mail, which leads to the American Medical Association recognizing birth control as a part of medical practice. In the 1940s, the diaphragm is considered to be the most effective form of contraception, but it's not popular due to its high cost and its requirement to see a doctor. Then in 1953, the philanthropist Catherine McCormick funds what's called the Pill Project. This protocol, which is developed by two physicians, is tested on patients in a nearby state psychiatric hospital, which leads to large-scale clinical trials for this pill, which are launched in Puerto Rico. Eventually, in 1956, Inovid is the first contraceptive pill submitted to the FDA for approval for severe menstrual disorders, so not yet for contraception. In 1957, additional trials for this pill are initiated in Mexico City and Haiti. By 1959, over 500,000 women in America are taking Inovid. And by 1960, the manufacturer of Inovid Searle is making $37 million in profit. So you can see it's a profitable drug very quickly. However, in 1962, word starts to spread of serious side effects from the pill, which includes 132 reports of blood clots and 11 deaths. But the manufacturer reports that there is no conclusive evidence of a link to the pill. By 1964, a quarter of all couples in America are using the pill. And then in 1965, the Supreme Court ruling in Griswold v. Connecticut acknowledges that married couples have a right to privacy, which includes the right to use birth control. In 1968, the FDA approved intrauterine devices. And at the same time, in the 1970s, the Indian Health Service sterilizes thousands of Native American women. 1974, the FDA suspends the sale of the Dalkon Shield after users develop infections and 7 die. From the 1980s to the 2000s, there was a boom in the development of contraceptive methods that were developed and introduced to the public, including several that you will notice by name here, including Paragard, Norplant or Implanon, the internal condom, Previn or Plan B, Essure, Mirena, NuvaRing, and Depo-Provera. And then in 2010, Congress passed the ACA, which included contraception as preventive health care. In 2013 and 2014, North Carolina created the Office for Justice Sterilization Victims, and Virginia establishes the Victims of Eugenic Sterilization Compensation Program. In 2014, the Supreme Court ruling in Burwell v. Hobby Lobby Stores permits religious exemption for ACA coverage for contraception. And then in a ruling in 2022, Supreme Court Justice Thomas suggested revisiting the ruling from Griswold, which granted privacy rights for contraception. And then bringing us to today, we of course have new contraceptive technologies that continue to be developed, really in the sphere of contraceptive options for men. And then we have several threats to contraceptive care access, some of the barriers that I talked about earlier, and then some other things too. So, when you were talking about the history of contraception, we have to acknowledge that at the same time as there being benefits to developing contraceptive methods, there are instances in which contraception was used as a tool for racism, coercion, and eugenics. I mentioned Margaret Sanger earlier, who coined the term birth control. She was a known eugenicist and spoke about targeting contraception at people of color, mentally ill people, disabled people, and the poor. Informed consent was not obtained by the people who were experimented on in the development of contraceptive methods. As an example, Puerto Rico was targeted for the trials for the pill because they were poor and less educated. And the assumption was that if they could adhere to this simple protocol, taking the pill for a few weeks and then having one pill off to have your menstrual cycle, then anyone could. And provider implicit and explicit bias can also lead to people who are deemed not acceptable disproportionately receiving or being steered towards some methods. For example, even 10 years ago, with the development of tiered effectiveness counseling, it led to an emphasis in LARCs first and patients being steered towards LARCs as their primary method. However, LARCs typically require removal from a medical provider. And then I'm sure some of you have heard of the history of what's called the Mississippi appendectomy, which was made famous by the civil rights activist Fannie Lou Hamer, in which patients would go in for a procedure that was not related to contraception and would leave having had a procedure plus a removal of their reproductive organs against their will or without their consent. This is a quote from a person who was interviewed by Time magazine in 2024 about her experience giving birth in Alabama in 2020. And I'm going to read the quote to you. Frazan was woozy from her epidural, but had experienced a traumatic birth. And at that moment, she didn't think she wanted more children. So she allowed the doctor to insert the Mirena, an intrauterine device that would prevent pregnancies for up to 8 years. In the months that followed, she didn't like the way the IUD was making her feel. But Frazan says she couldn't persuade her gynecologist to take it out. The doctor told her she needed to lose weight first, Frazan recalls, and that there were medicines to offset the side effects she was experiencing, such as nausea. It would be 3 years before Frazan could get the device removed. Even then, she had to undergo 3 procedures, one lasting 7 hours, she says, because the device had migrated to the lining of her uterus. It left her with 4 thumb-sized scars on her belly from where a doctor inserted an instrument to try to find the IUD. The experience caused Frazan, a 32-year-old hairdresser, to have a profound mistrust of the medical system. Quote, "I don't have faith in doctors anymore," she says. "I can't trust any of them." So this experience embodies what I was talking about earlier, that, bias towards who should have children and who should not can often come up in medical practice. And this experience was from 2020. So this isn't something that happened a long time ago. This is still something that can occur. So just a note on what's referred to as soft sterilization, which is what I just described, the insertion of an IUD or an implant and refusal to remove it. That this has been used in situations with people who are imprisoned or are on public assistance. So, for example, in 1991, 92, and 93, legislators in more than a dozen states introduced measures that, had they passed, would have coerced women to use Norplant. Some of these bills would have offered financial incentives to women on welfare to induce them to use Norplant. Other legislation would have required women receiving public assistance either to use Norplant or to lose their benefits. And then in 2017, a judge in Tennessee offered incarcerated people 30 days off their sentence if they would receive either a vasectomy or an Explanon. So, in talking about all of those things and the history of contraception, there are those of us who work in this space to bring a lens of equity and justice to our work, to both acknowledge the historical wrongdoing and also focus on high quality, person centered care so that everyone can receive contraception in the way that they want to and on their own terms. Contraceptive equity is a term that is defined by the National Health Law Program, and it means that every person can make their own decisions about pregnancy prevention, and contraceptive care is easily accessible and covered at no cost at all health programs. It requires acknowledging the critical role that family planning plays in improving health outcomes and economic security for people of reproductive age and their families, while simultaneously grappling with the country's history of reproductive coercion. Contraceptive justice is another framework created with a coalition of reproductive health rights and justice advocates and community experts that operationalizes reproductive justice for contraceptive care using 13 domains of high quality health care. It is the concept that all people deserve the social, political, and economic power, rights, access, and resources to receive contraceptive care aligned with these domains of quality. So this is the lens that we take in our work and the approach that we have to the work that we do in South Carolina. So I'm going to talk some about our program and go into our mission and vision. So our mission is to transform healthcare in partnership with communities, providers, and patients to ensure that everyone can obtain high-quality sexual and reproductive health services. We envision a world in which all people have the knowledge, access, resources, and freedom needed to make decisions about and obtain sexual and reproductive health care. And here's some of the ways that we realize this vision. We empower South Carolinians with the knowledge, tools, and support to make informed decisions and access the sexual and reproductive health care that they need on their own terms. We educate the public about their sexual and reproductive health options through a program that's called No Drama. We train healthcare providers and other professionals in diverse topics that center on the patient's experiences, values, and sexual and reproductive health needs. We ensure that the provision of respectful, high-quality sexual and reproductive health care is a core tenet of primary care. We improve statewide health outcomes by creating more equitable access to sexual and reproductive health care. We collaborate with other organizations and stakeholder groups whose missions will advance the provision of sexual and reproductive health. We lead by example, demonstrating how our core values, practical experience, and validated models of care can inform a program that changes the landscape of sexual and reproductive health care access at multiple socioecological levels. And we inspire innovation in the field by rigorously evaluating and optimizing our work, disseminating our findings, and leading shared learning opportunities. So just to give you an idea about the state of South Carolina and what we're working in addition to the barriers that I already discussed, there's over 300,000 women in South Carolina that are in need of publicly subsidized contraception. Over a third of South Carolina counties have no practicing OBGYN. As you all know, people in rural areas are less likely to have a provider who offers contraception. And South Carolina has some limitations by not being a Medicaid expansion state, which means that there's some people who fall into a gap. And even as recently as 2023, PIBA dependents did not receive contraceptive care coverage prior to 2023. So there's been some big spaces of gaps for people with coverage for contraception. So we started our program in 2017. And we have a statewide network of 120 plus partner clinics and a telehealth provider. These clinics are located all over the state. We work with rural health clinics, FQHCs, hospital inpatient settings and outpatient settings, and some free clinics. As I described, we focus on contraceptive equity. So that includes offering free or low cost methods for both uninsured and underinsured people and free removals of any device. We offer capacity building and technical assistance to our partner network so that they can offer these services in a patient-centered way, but also in a sustainable way. We have a training website that covers various sexual and reproductive health topics that is free and open to anyone in South Carolina. We also employ evaluation and strategic learning so that we can understand the quality of the care that's being offered and whether or not there are any gaps in service delivery. And then I mentioned earlier, we have a comprehensive patient education campaign that's called No Drama. The center of that is nodrama.org, and you can visit that website or have a patient visit that website, and they can find a clinic that is local to them. So here are some of the facilitators of contraceptive access that we focus on. Providing convenient access points in people's local communities. So we have put a lot of work through our partnership with the South Carolina Office of Rural Health into building up rural health clinics so that people don't have to travel to metropolitan areas to receive the same quality care that they would have to go to get there, but they can receive it in their backyard or their neighborhood. Um, Ensuring that methods are stocked. So we provide grants to clinics so that they can have methods on the shelf and available if someone wants a initiation of a same-day method. We eliminate cost barriers for all methods, and that includes the more expensive ones like LARCs, which can be upwards of $1,300 out of pocket for someone who is uninsured. Even the less costly birth control methods, like pills, can still cost $10, $20, $30, and for some people, that is out of reach for them. So we also cover the cost of that. I mentioned we cover the cost of removal so that that is not a barrier for someone who wants to get a device removed. So we work with a network of clinics where we provide grants, but you are not required to have received your method, your device at one of our partnering clinics for us to pay for it to be removed. We train providers in LARC insertion and person-centered care practices. There is a gap in provider knowledge around LARC insertion that can lead to people not being able to get a LARC if they want one. So we train both practicing providers and also students, including nursing students, and we work with several residency programs across the state to train them so that they can offer this service. We have on our website a few pages that are dedicated to educating the public about methods, where they can plug and play and ask questions and receive more information about potential side effects or if a method would be contraindicated for them. And we make it easy for them to find a place for them to go. So if you go to our website or if you have a person who needs to go to find contraception, we have a pop-up that has a chat feature. So if you're experiencing any issues, you can talk to a person. We have a telehealth program that is linked directly there where you can go and get an appointment that is convenient for you. And then we also have a feature where you can put in your zip code and it will pop up with the closest clinic that works with us. In addition to that, we have a patient advocate that you can talk to who will help you if you are having any issues navigating the healthcare system in order to get the contraception that you need or a bridge method. We also work on ensuring that public resources are being used effectively. And I mentioned previously making sure that these services are sustainable. We don't want the service to be a burden financially on clinics because we want them to be able to offer this forever. So we help clinics be able to use Medicaid effectively and to sign people up for family planning Medicaid if they qualify. And then we evaluate service provision for gaps in access or quality. We collect data from the clinics that we work with. We feed the data back to them so that they can understand where they could boost service delivery. So I'll provide some notes now about some of the impact that we've seen from our program. So as I said, we started in 2017, and from 2017 to June 2024, we have provided services to over 500,000 people in South Carolina. And contraceptive services is defined as either a method, contraceptive counseling, or both. In addition to that, we've trained over 9,000 people in the state. And we were fortunate to have an external evaluation that was independently funded from us that looked at all dimensions of our service delivery. And they were able to look at some of the items that we were very interested in, including patient-centered care. So what they did was have a comparison state of Alabama, which is similar in size and makeup to us. And they asked clinics, people going to clinics in Alabama and people going to the clinics that we work with about the quality of care that they received. And by and large, our patients reported that the care they received from their providers was more person-centered and more respectful. And they were able to demonstrate through their evaluation that more people in South Carolina were able to access the full range of methods in our clinics compared to other clinics in Alabama. So we focus on patient empowerment, education, and creating an environment that supports patients' contraceptive choices. Many scholars and advocates rightfully push back against an overemphasis on unintended pregnancy as a construct. If you are not familiar with what unintended pregnancy is, it's a measure that is taken from people who have just experienced birth, and it asks them to reflect back on their pregnancy of whether it was planned or mistimed. So I did not want to be pregnant at all, or I wanted to be pregnant, but later than what I was. So, scholars and advocates talk about this as a construct that doesn't always apply to everyone in the field. It doesn't always really embody the experience that a lot of pregnant people have. However, that is one of the best outcome measures that is available to understand the impact of a program like ours. So, we do track unintended pregnancy, which is collected through the Pregnancy Risk Assessment Monitoring System. Unintended pregnancy is known to be connected to adverse health outcomes for birthing people and children, and it's also a focus for funders and for the government to understand impact. And from 2017 to 2022, South Carolina saw a 58% decline in unwanted births and a 28% increase in intended births. So even acknowledging the limitations of this measure, we still see some positives in the trend of increasing intention in births, which tend to be healthier and have healthier outcomes. So as we're looking forward, New Morning is continuing to promote access to high quality contraceptive services. We are also looking at expanding with our knowledge and expertise into other sexual and reproductive health services like STI prevention and treatment and basic fertility, as well as pre-pregnancy care. We're identifying areas of South Carolina where services are lacking or there are barriers to care to increase access. We're broadening our collaborations and sharing our strategies with other stakeholders, such as yourself. We're increasing our training offerings and expanding our impact to people even outside of South Carolina. Just as a note here, if there is a training that you are interested in, a topic, please let us know. We do offer these for free with CEUs and CMEs. We both have web-based and in-person IUD trainings. We can also host an on-site LARC training for providers and residents with no cost to you. And then in addition to this, we are seeking ways to diversify our funding to ensure that we continue to be sustainable. So I was asked to talk about the current state of access to contraception, given the political situation that we are in right now. Not a lot is known at this exact moment, but there's a couple of things that have been pointed out, including threats to the Title X Family Planning Program, which is the federal program for family planning. This is something, again, that we do not know about at this point. If there was something that was done to dismantle or to greatly reduce the Title X Family Planning Program, what we could expect is that cost barriers would persist and would be exacerbated. And what is also projected is that there would be more of an emphasis on abstinence-only services. What this really means in practicality is organizations like ours would be in a place where we would have to offer even more services. We are not funded through the Title X Family Planning Program. And so we would expect that the clinics that we work with would see an uptick in people that needed subsidized care. I talked about this earlier, but disinformation is really something that has made it difficult for providers, I know, in conversations with their patients, and even to message to people through education about different birth control methods, and these things abound. And even some recent research that came out of the UK showed that there's been a proliferation of people who are relying on the rhythm method for their contraceptive method based on what they learned in social media, and that they saw an uptick as a result of that among those people in unwanted or unintended pregnancy. There's more scrutiny that can be placed on providers, and more pressure on what providers talk about with their patients in terms of contraception. There's also a recent removal of data and information from government websites, including the 2024 Quality Family Planning Guidelines and the medical eligibility criteria. Those things can still be found on other websites, but they were removed from the Office of Population Affairs. And then something that it has been persistent in our field, but is definitely of more concern, is just the lack of privacy and confidentiality for people who are seeking these services. So here's some ways that you can help New Morning if you are interested. If you want to share our story to gain more awareness of our work, we are in the news sometimes. And if you follow us on LinkedIn or our social media, you can be tapped into those. You can also find it on our website. You can connect us with other stakeholders that might be interested in collaborating or learning more about what we do. At our core, we are just interested in getting people access to contraception. And so the more people know about this resource, the more that the patients can get what they want. You can introduce us or share information with potential funders if you know any. You can share and use our training website. We really try to tailor those trainings to what the needs of the state are. Those trainings are not just about contraception, they are about all aspects of sexual and reproductive health. And we do host a yearly sexual and reproductive health conference in Columbia. In addition to that, when we are in the news, we always get requests for external validators. So if we are saying something about the impact of our program, if you would be willing to talk about that, that would be great. Here is a QR code if you're interested in finding out more about our summit. It covers education on a lot of the topics that I have been talking about today. And here's some sources. I just put links in here so you can click through them, make it a little bit easier. So here's some of the things that I pulled from. And that's the end of my talk. And if you have any questions for me,